Welcome back to our video today on endocrine disorders or endocrine pathology. And we're going to talk about what happens with the various different endocrine glands. So basically you have the hypothalamus and the pituitary, and then you have some other type of gland. And so there is going to be something wrong in the brain or something wrong with the pituitary gland or something wrong with the gland that they interact with. Like in this picture, this is the thyroid gland. And we're going to be secreting too much of some kind of hormone or too little of some type of hormone. So we're going to go through the different organs such as the pituitary, thyroid, adrenals, and the pancreas. And then we're going to talk about non-neoplastic diseases, which would basically be non-cancerous. And again, this is all about too much of a hormone or too little of a hormone. And then we'll touch on some of the different types of cancers, which would be benign or malignant. And so we're going to go through hyperpituitarism and hypopituitarism. And then prior to that, I'll give you a little introduction talking about the hypothalamus and the pituitary gland. So as you can see here, this is a pituitary gland. And the pituitary gland is divided into two parts. You have the anterior pituitary and the posterior pituitary. The anterior pituitary is referred to as the adrenal hypophysis, and it secretes several different hormones. So you have growth hormone, you have adrenocorticotropic hormone, you have thyroid stimulating hormone, luteinizing hormone, follicle stimulating hormone, and prolactin. And this is controlled by hormones secreted from the hypothalamus, and each one of these hormones that are going to stimulate the anterior pituitary are all referred to as releasing hormones. So most of the problems that we have as far as endocrine disorders are going to involve the anterior pituitary. The posterior pituitary is referred to as the neurohypophysis, and this region secretes two hormones. One is oxytocin, the other is antidiuretic hormone, also known as vasopressin. So these hormones, and we'll talk about this in a little bit, are made in the hypothalamus, but then they are stored and secreted in the posterior pituitary. So in this picture here, you can see here is the thalamus, and then below the thalamus would be the hypothalamus, and then sitting below the hypothalamus, you have the anterior posterior pituitary. And in this picture, you can see here is the anterior pituitary, here's the posterior pituitary, and then above this is the hypothalamus, and then this is connected to the anterior pituitary, which we'll talk about in just a second. And so you can see it a little bit better here, although it's backward in this picture. This is the anterior pituitary, posterior pituitary. So in the hypothalamus, there are groups of neurons or groups of cell bodies which are called nuclei. And these nuclei are all given different names, like this is the supraoptic nuclei, paraventricular nuclei. And so each of these, okay, are going to be producing particular types of chemicals that are going to be used as hormones. So these are made in neurons, but they are secreted into the bloodstream, and so these are considered a neuro type of hormone. So for the anterior pituitary, the hormones that are released from the hypothalamus here to stimulate the anterior pituitary, but they're released into this portal system here that then stimulates the anterior pituitary to, let's say, release ACTH or TSH. The hormones that are released, these neurons have very short axons, and so they're released into this bloodstream, and we refer to these as releasing hormones. On the other hand, if you're talking about the posterior pituitary, notice that these neurons have very long axons, and those hormones then are stored in the posterior pituitary and then released into the bloodstream, and oxytocin and ADH are going to then be released into the system, into the systemic blood, in order to have some type of effect. This is a picture looking at anterior pituitary, posterior pituitary. So you can see that the cells are very, very different in each of these regions. And these cells in the anterior pituitary a lot of times are referred to as trophic cells. These cells are producing the hormones, the ACTH, TSH, LH, and so on. Whereas the cells in the posterior pituitary, these cells are not producing hormones because the neurons are storing those hormones and then releasing them into the bloodstream. So they're very, very different. When we have hyperpituitarism, this is too much of a particular type or types of anterior pituitary hormones. The most common reason is because of a pituitary adenoma. So the symptoms might be none for a while until it gets very large, and then you have various different types of endocrine abnormalities because too much of these hormones are being secreted. And then once the pituitary gets large enough, you have some type of an effect on the brain and on the body. And so this is a pituitary adenoma right here. This is the sphenoid sinus that it's supposed to sit in. The pituitary gland should be very, very small, and of course this is extremely enlarged. And then you can also see that pituitary sitting right here, and this is very, very enlarged. And now see the difference in these trophic cells because now they have become cancerous. So if we have a growth hormone adenoma, what is happening is this person is producing too much growth hormone, and it produces either gigantism or acromegaly. Now, other findings can be that the person also has diabetes, hypertension, arthritis, and then even developing gastrointestinal carcinoma. Now, gigantism is where our individual is going to grow very, very tall. And the way that someone is going to experience gigantism is if this pituitary adenoma is occurring prior to fusion of the epiphyseal plates. So that means that the bones are able to still be stimulated by growth hormone and they're able to grow lengthwise. Now they do grow in width as well, but if the growth plates are fused, then those bones are not able to grow lengthwise, and now we have a person who has acromegaly. And with acromegaly, this individual's bones are going to just grow in width. So with lab findings, we're going to see growth hormone is up. There's also an increase in IGF-1, which is insulin-like growth factor. And growth hormone and IGF-1, they both work together to cause muscles and bones to grow. Now, growth hormone is also unresponsive to glucose. Now, growth hormone counteracts basically the effects of insulin on glucose and lipid metabolism. So what happens is growth hormone is going to negatively affect insulin so that glucose levels can go up. In people who have this growth hormone adenoma and you have growth hormone excess, like in acromegaly, they're going to have these different regulations of glucose. In these patients, increase glucose production, decrease muscle glucose uptake, and increase blood glucose levels are seen in all of these patients. So here are just some pictures of, at the time, the tallest people in the world, and you can see that gigantism, as I show you, seems to affect males more than females. This is a 12-year-old boy with gigantism. This was the tallest man in the world in 2008. Now, one of the things that you should know is that growth hormone is not just affecting the bones and the muscles. Growth hormone also affects all of the body systems. So it's going to affect the heart, it's going to affect the liver. It makes everything grow, but you don't grow normally. The body isn't genetically made to be this tall. So these individuals are very sickly. They have cardiovascular issues, they have joint issues, they're in pain quite often, and so their lives are very difficult. So this gentleman you just saw the picture of, his name is Bao Zhang, and he's 7'9" tall. He did lose his title to a Ukrainian who became the tallest man in the world. Leonid Stadnik, who was 36, lives in this poor little village in northwest Ukraine, and he was 8 feet 5.5 inches tall, and he is more than 8 inches taller than Bao. And Stadnik's growth spurt started at the age of 14 after a brain operation apparently stimulated his pituitary gland. And so you can see he was the tallest man in the world in 2009. In 2010, we have another gentleman who was even taller. And you can see again walking on a cane. I don't know if you remember Andre the Giant. He was in wrestling and in some movies. Now, Andre the Giant, let's just go back for a second. Although he was tall, he also had very large features, and he had a little bit of acromegaly along with gigantism. And you can see in these gentlemen the acromegaly increasing the facial features. And then this is a very good picture, development over time of the acromegaly, how it causes the facial features to widen because the bones are becoming thicker. So other pituitary adenomas, prolactinoma, ACTH producing adenoma, FSH, LH producing, TSH producing, and then there's what's called a non-functioning adenoma. So what that is that the pituitary is larger but not necessarily producing any extra hormones. So in order to remove that adenoma, what they're going to do is go up through the nose and open up into the sella turcica and then get to the pituitary this way in order to remove the adenoma. Hypopituitarism is where we're producing too little of these anterior pituitary hormones, and this could be due to destruction of the pituitary gland. You have what's called ischemic necrosis, and this is caused by hypoxia because there's not enough blood supply. And then you also have what's called pituitary apoplexy, which is bleeding into or impaired blood supply to the pituitary gland. Symptoms usually are insidious. They happen slowly. You may have, for instance, dwarfism, loss of libido, menstrual abnormalities in females, hypothyroidism, adrenal insufficiencies. And these things can even happen in animals. So I thought you'd like to see this. This is actually a German Shepherd who is also a dwarf German Shepherd. Cute, huh? although that is not a healthy dog. That is actually a pituitary malfunction. Now, we also have thyroid pathologies that we need to talk about, and what we're going to go through would be hyperthyroidism, hypothyroidism, non-neoplastic diseases, and then neoplasms of the thyroid. And so you can see here, this is the thyroid gland, and it has a little isthmus here where it connects it like it's a little butterfly. This is the larynx here, and so you can see in close proximity to the thyroid. Normal thyroid follicles where the hormones are going to be produced, and inside there is a kind of glob, sort of mucousy like thyroglobulin. Now, tertiary, secondary, primary, TRH is coming from the hypothalamus. This is thyroid releasing hormone. That is secreted to stimulate the anterior pituitary to release TSH, or thyroid stimulating hormone. Thyroid stimulating hormone then goes to the thyroid gland and causes the thyroid gland to produce the thyroid hormones. And the two major thyroid hormones the thyroid gland is producing is T3 and T4. T3 stands for triiodothyronine. T4 is thyroxine. Now remember, all of these hormones we talk about are controlled by negative feedback. So TRH, coming from the hypothalamus, is going to stimulate TSH. TSH is going to stimulate T3 and T4. And T3 and T4 is going to get into the bloodstream, and it's going to stimulate pretty much every cell in the human body. And we're going to talk about this, but one of the major things that T3 and T4 does for us is it keeps our metabolism up and running. So you don't want too little, you don't want too much T3 and T4, because you don't want your metabolism to be too low, you don't want your metabolism to be too high. So most thyroid hormone is bound to a protein as it circulates through our bloodstream. So T3 and T4 is bound to this protein, and only once it's not bound to the protein is it in the free form and is the T3 and T4 now active. So the thyroid hormone, once it's active, it's going to pass through the cell membrane and to the nucleus, and it binds to nuclear receptors. So T3 and T4 do not bind to receptors on the outside of our cells. They bind to receptors in our nucleus. And then the idea is once it does that, it's going to be able to stimulate the DNA to change gene expression. And so what that means is it's going to then turn certain genes on or turn certain genes off so that the cells now produce either more or less of particular types of proteins. And then once those proteins are produced, for instance, maybe we're producing certain enzymes, we can increase carbohydrate breakdown and increase fat breakdown, which of course would then increase the amount of energy someone has in their cell, in their body. It also stimulates protein synthesis. And the results are you have an increased basal metabolic rate. So when we're doing lab tests, there are a couple different tests that are done, and the two simplest tests are to test for TSH, our thyroid stimulating hormone, and T4. And of course, if TSH is high, okay, that's going to stimulate the thyroid to produce T3 and T4. Now remember, we talked about this being on a negative feedback. As T3 and T4 go up and up and up, the higher up they go, they're eventually going to feed back onto the thyroid gland, and they're going to cause TSH levels to go down. So we don't want too high of a TSH because we would be stimulating too much T3 and T4, and so we need to turn that off for a while once the T3 and T4 levels go up. So when we're looking at the thyroid, we have hyperthyroid, we have hypothyroid, and then if it's a normal range, we have what's called euthyroid. So if you have normal levels of T4, you have normal levels of TSH, we're going to consider this euthyroid. Now, if your TSH levels are low, but your T4 levels are high, you have what's called primary hyperthyroidism. And primary means, and let's go back to this picture. Remember, primary means something's happening at the thyroid gland itself. Secondary at the pituitary, tertiary at the hypothalamus. If TSH levels are high and T4 levels are high, then what's going on is something is happening either at the pituitary or at the hypothalamus to drive both TSH and T4 levels up. If TSH is high but T4 levels are low, you have what's called primary hypothyroidism, which means that something's wrong with the thyroid gland itself. And the reason the TSH levels are high is because the brain and the pituitary are going, whoa, hang on a second. T3 and T4 are too low in the body. Let's try to make more TSH, more TSH, more TSH, and knock on that thyroid and say, hey, wake up, make more T3 and T4, but there's something wrong with the thyroid and it can't. So your TSH levels are high, your T4 levels are going to be low. Secondary or tertiary hypothyroidism is where both the TSH and the T4 levels are low. And so something, again, is wrong with the anterior pituitary or with the hypothyroid in this case. Or, excuse me, with the hypothalamus. You can have what's called subclinical hypo or hyperthyroidism, which means that your TSH levels may be low or may be high, but your T4 levels are normal. And so they're not going to treat an individual with this subclinical hyper or hypothyroidism, which is really kind of too bad because now your patient has to wait sometimes 10, 15 years until something happens where their thyroid really gives out or they notice something wrong with the pituitary or whatever it may be before they get treated. And so they're living those 10, 15 years with no treatment, and they're living as if they have hyper or hypothyroid. They have the symptoms of this, but the medical profession typically does not treat this. So hyperthyroidism, this is where our metabolism is hyper, too high, because we're producing too many thyroid hormones. And some of the symptoms, rapid pulse, arrhythmias, tremors in the muscles, emotional lability, which means the person can be depressed, they can be all of a sudden giddy, they can be angry, they can be happy, and within a blink of an eye. You can have what's called lid lag, and I'll show you a picture of that where the lid is not blinking and closing appropriately. They also have very warm, sweaty skin, diarrhea, osteoporosis, and then there is the possibility that thyroid hormone levels can go up so high that you have what's referred to as a thyroid storm. And this is very dangerous to the person. This is lid lag, where the eyelids are not able to move appropriately. Hypothyroidism is where you have a hypometabolic state because the person is not producing enough T3 and T4. And so everything is slowing down. They have slowing of the mind, slowing of the body. They also have myxedema, which is where they produce this thick mucus that gathers underneath the surface of the skin. And it actually is really thick and causes the skin to stick to the muscles below. And it leads to a lot of swelling in the person. Their pulse is very slow, sometimes in the 30s. They have constipation because their muscles just don't work and they don't have a lot of peristalsis going on. The skin is very dry. They look scaly, cool, and pale. They have cold intolerance, delayed reflexes, and if the hypothyroidism is bad enough, they can go into what we call a myxedema coma. And so you can see on the left, A, this is a woman before treatment who has this myxedema and all of the swelling that she has from it, and then after treatment. And one of the things you can really see with someone who has very severe hypothyroidism in this case is how swollen the neck is where the thyroid is located. Even look at the difference with the texture of the hair. One of the other things you see with hypothyroidism, and you can see this here, is the outer third of the eyebrows go away. It's kind of interesting because in the good old days, you didn't have all of these lab tests and blood work that you could do for hypothyroidism. So how is the doctor going to be able to tell if a patient has hypothyroidism or not? And so there were little things like, for instance, looking at that outer third of the eyebrows. Your patient doesn't have those, well, they probably have hypothyroidism. Or if you couldn't pinch the skin and pull the skin up away from the muscle below, that was probably hypothyroidism. If the person slumped forward and had droopy eyelids, which you can see obviously here, because they need a lot of energy to keep those muscles up and the eyes open, there was probably some hypothyroidism going on. So there were different ways of being able to diagnose your patient. There's also congenital hypothyroidism, and this can be a genetic issue or an iodine deficiency. And notice how swollen these little kids, their stomach is. They have what we call ascites, and that's because of inappropriate protein production. They don't produce enough protein. And then also notice the swelling in the face, especially right here. So congenital hypothyroidism, the symptoms can be mild to severe. Of course, the treatment for any hypothyroidism is replacement of the thyroid hormones. And then, of course, the other thing too is iodine deficiency can be prevented. Now, we get iodine from the soil, and that iodine can be replaced if we don't have enough iodine in the soil. So that's why, for instance, in the United States, we don't have a lot of iodine in our soil, and so we add iodine to the salt. And so you have iodized salt. Now, a lot of people lately have been changing from this regular salt to sea salt, and sea salt is typically not iodized. There's not a lot of iodine in it. So if you're going to use sea salt, you probably need to make sure you're purchasing iodized sea salt in order to keep the thyroid healthy. So thyroiditis is inflammation of the thyroid gland, and you have a couple different types of thyroiditis. The one that is most common is Hashimoto's thyroiditis, but there's also lymphocytic thyroiditis. There's de Quervain and fibrosing thyroiditis as well. Now, Hashimoto's thyroiditis, again, this is the most common type in the United States. It's much more common in females than males, and it is an autoimmune disease. And so what happens is, of course, this is genetic, and now all of a sudden, usually a person will say there was like this massive stress in my life, and then I had Hashimoto's. And so stress can cause changes to the DNA, and something like Hashimoto's can come out in the person. And so the person, their immune system starts making antibodies that can destroy the thyroid gland. So for instance, there are TPO and TG antibodies. TPO stands for thyroid peroxidase antibodies, and then TG is thyroglobulin antibodies. And of course, when a person is doing blood work, these antibodies can be tested to see if a person's hypothyroidism is actually Hashimoto's. And this is showing you Hashimoto's. And notice right here, you have these little kind of pinkish looking areas. These are called hurdle cells, which are common in Hashimoto's. And so when they do a biopsy of the neck, they can see these cells. And these are enlarged epithelial cells. They have eosinophilic granules in the cytoplasm, and that's because of alterations in the mitochondria. Now, in a person who has hypothyroidism, the mitochondria don't work as well. They don't produce as much ATP. In de Quervain's thyroiditis, this may look scary. The person has swelling in the thyroid, but usually this type of thyroiditis is going to come and go, and it usually goes away pretty quickly without causing too much problem in the person. Sometimes this is called subacute granulomatous thyroiditis or giant cell thyroiditis, typically painless. Some cases could be viral in origin. So for instance, somebody has an upper respiratory infection and then all of a sudden their thyroid is swollen and they have some hypothyroid symptoms. And then this is looking at a biopsy of the thyroid with this de Quervain thyroiditis. Silent thyroiditis can also be postpartum or middle age. It's also mild symptoms. And there are a lot of women who will have a baby, and then the stress, of course, of pregnancy and carrying the baby will cause a thyroiditis or a swelling of the thyroid leading to hypothyroid symptoms. And of course, one of the things that could happen is that the thyroid gland can swell and you get what we refer to as a goiter. Now, these people usually alternate between hyper and hypothyroid. And sometimes what will happen is they'll be hyper for a while and then they go hypo, and they can then stay hypo because the thyroid has basically burnt itself out being too hyper for too long, and then they stay hypo. And this is the cells from the inflammation of the thyroid. Then you also have the fibrosing thyroiditis or Rydell's and rock hard neck mass. And the problem is it can compress the trachea. So what happens is you have replacement of the normal thyroid tissue with this dense fibrous-like thyroid tissue. And it makes the thyroid hard as stone and fixed. And this inflammatory process can infiltrate the muscles. It can cause tracheal compression, and you're going to need surgery for this. But this is a very rare form of thyroiditis, and sometimes they call it like, when you look at the thyroid, it looks like kind of like woody pulp. Graves' disease is another autoimmune disease which then causes hyperthyroidism. And there is a basic triad with Graves' disease. You have the hyperthyroidism, ophthalmopathy, and dermopathy, which we'll talk about all three of these. Now, with Graves' disease, what happens is this autoimmune disease, now remember, the immune system is attacking the thyroid, and now we're going to make a different type of antibody, and these are called anti-TSH receptor antibodies. So what the antibodies do is they mimic TSH. So these antibodies are able to bind to the TSH receptors, and they stimulate thyroid growth. and they also cause T4 release. And now the thyroid gets enlarged and they have this goiter, and they also produce too much T4. They also have retroorbital tissues that are reacting to this excess in T4, and that's what causes the ophthalmopathy. And then, of course, it reacts to the skin of the legs, which I'll show you. There you go. And so you get this thickened, reddish looking skin, and especially in the pre-tibial area. And you can see the ophthalmopathy here. What happens is, well, actually, they're not actually totally sure what happens. Used to be thought that there was a lot of fluid buildup and pressure behind the eyes, which then pushed the eyes forward and made the eyes bulge. Now they believe that there is tissue that grows behind the eyes that causes the eyes to move forward. And once the person has the bulging eyes, then they're not able to, even if the Graves' disease is cured and goes away, those eyes don't go back to normal. And then you can see the skin lesions that occur, especially in the pretibial area. And this is pretibial myxedema. So a goiter generally is the term for a swollen or big thyroid gland. The Latin is gutar, and so you can see where we got the word from, and it's because of defective T4 synthesis. Now, one of the things you should know is that a goiter can happen if a person has hypo or hyperthyroid. So let's say we have a person who is iodine deficient. The reason that we call the thyroid hormones T3 and T4 is because of the number of iodine atoms that are part of this molecule. So T3 has 3 and T4 has 4 iodine. So if I'm iodine deficient, I can't produce T3 and T4. I'm not able to do that. So I have low T3 and T4 levels, and the brain goes, oh, holy crap, this is bad. We need to make more T3 and T4 to keep the metabolism up. And so what happens is the brain starts producing more TRH and more TSH. And so because of those increases in TRH and TSH, the thyroid can't respond appropriately because it doesn't have enough iodine, but we make more of that thyroglobulin, that sticky mucousy stuff, and it causes the thyroid to become larger. And with hypothyroid, you can also have a goiter. And so there you go. This is a small goiter that the patient has. There's a nice large goiter. So this woman is from Nepal, and it's quite normal for people in Nepal to have goiters. As a matter of fact, it's so normal that what the community did after a while is it just became a thing of beauty. And so the woman with the biggest goiter was considered the most beautiful female. Now this is from iodine deficiency, not enough iodine in the soil, and you don't really see this in Nepal anymore because they do iodize their salt now. So again, no iodine, we have a lack of T4, we have increase in TSH, it makes the thyroid become larger. There can be problems in enzymes like that TPO, TG enzyme where we can't produce enough T4 and we get the same goiter effect.